Hi, my name is Angela Craig, and I'm glad everybody could come out today to discuss the core measure of sepsis. My role is I am the sepsis team coordinator for this hospital, and we recently in March just became sepsis certified with the Joint Commission. I'm also the clinical nurse specialist of ICU, so you'll see me up there on the units. If anybody ever has any questions as you see me around the hospital, feel free to let me know. Sepsis is a love of mine, and I know that we have made big strides and made great changes in the lives of our sepsis patients. Linda Richardson is our sepsis abstractor, and she is definitely the guru for all of these core measures and these abstractions. So by all means, if you have questions, she's in the quality department as well. As you all, I'm sure, are aware, sepsis is incredibly burdensome to healthcare. It's the sixth most common reason for hospitalization, as well as the major cause of morbidity and mortality worldwide. In the U.S., more than 700 patients die of severe sepsis daily. As you can see, this number is very alarming, and there's a lot we can do to decrease deaths for severe sepsis. Now, it's going to become increasingly important that we're all very clear on where our patient lies on the sepsis continuum. So I want to review what sepsis is, what severe sepsis is, and what septic shock is. Sepsis is a known or suspected infection and 2 or more SIRS. SIRS criteria is the systemic inflammatory response that kicks in due to an event or injury or infection. And our SIRS criteria is temperature greater than 100.4 or less than 96.8. And that's what we use at this hospital. I will tell you that the core measures per CMS go with greater than or equal to 100.9. Heart rate greater than 90 beats per minute, respirations greater than 20, and white count greater than 12,000, less than 4,000, or greater than 10% immature neutrophils, which we call bandemia here. So known or suspected infection plus 2 or more of that criteria is equivalent to sepsis. But let me remind you, there are those patients who don't always show SIRS criteria the same. Immunocompromised patients or patients who are on beta blockers may not show the same white count or heart rate that you would expect from a normal patient. Severe sepsis is known or suspected infection, 2 or more SIRS, and organ dysfunction. Organ dysfunction is evidenced by any one of the following that you see on this screen. So a systolic blood pressure of less than 90, a MAP of less than 65, or a systolic blood pressure decrease of more than 40 points, or if patient is already on a vasopressor, that all counts for cardiac being down. Creatinine of greater than 2 or urine output less than 0.5 mils per kg per hour times 2 hours, that means renals down. As far as respiratory, increased oxygen requirements, bilirubin greater than 2 milligrams per deciliter, platelet counts low, less than 100,000, INR greater than 1.5, or PTT greater than 60 seconds, or a lactate greater than 2. All of those are specific for the different organs that are down related to possibly sepsis. So remembering that sepsis is a disease of hypoperfusion, and as we have organs that are affected unrelated to what they came in with, then it's just a disease of hypoperfusion. So we're trying to see how many organs are down unrelated to the issue that they came in with. So let's go back to this screen here where we talk about the continuum. We've talked about sepsis, we've talked about severe sepsis. Now let's talk about septic shock and the criteria for septic shock. Septic shock is severe sepsis plus a lactic acid greater than or equal to 4 or hypotension after a 30 ml per kg fluid bolus. So I'm going to switch over to a few slides here that talk about the criteria, and you can see documentation of severe sepsis is present, and then tissue hypoperfusion persists in the hour after crystalloid fluid administration, evidenced by a low blood pressure, so that can be systolic blood pressure less than 90, MAP less than 65, or a decrease in systolic blood pressure by greater than 40 points, or that lactic acid level of greater than or equal to 4. So it's important that we all know this criteria because we have bundles that are associated with these diagnoses. So beginning October 1st, 2015, we have this mandatory core measure. The focus is on those patients with a diagnosis of severe sepsis or septic shock. And there is an emphasis on early management, and that is why you're going to many times see time frames associated with what we need to do for these patients. It is consistent with the Surviving Sepsis Guidelines and recommendations, and the purpose of this measure is really to bring about reduction in overall organ failure, hospital mortality, length of stay, and cost of care. And this is an all or nothing bundle, so we have to be very careful that we get all of these elements completed in the time frames that are required in order to get credit for them. Now, there are some inclusion and exclusion criteria that I want to share with you, but I would want you to be cautious with the exclusion criteria. Just know if your patient has severe sepsis or septic shock that you treat them to the best of your ability, and just know that our abstractors will be able to pull out charts that aren't appropriate that fall out. But I did want to let you know what some of those criteria are. This is an adult-only bundle, so age 18 or over. You can see with the ICD-10 CM principle or other diagnosis code of sepsis, severe sepsis, or septic shock. And there is exclusion criteria. So our exclusion criteria will be those patients that are less than the age of 18. Also, patients with a length of stay greater than 120 days. Patients with a directive for comfort measures must be documented by the provider within 3 hours of presentation of severe sepsis in order for that chart not to count. So for our abstractor to pull that out within 3 hours. And then for patients for comfort measures documented by provider within 6 hours of presentation for those with septic shock. So we get a little longer for the septic shock patients. Patients who are transferred in from another acute care facility, as well as patients with severe sepsis who expire within 3 hours of presentation, and patients with septic shock who expire within 6 hours of presentation. And then patient or caregiver refusal for care, so blood draws, fluid administration, and antibiotics, that needs to be documented by a provider, or it can have a witness consent saying they do not want those or they're refusing care. As long as that is in the medical record and documented, that should be fine. And then patients receiving IV antibiotics for more than 24 hours prior to presentation with severe sepsis, those patients will also be excluded. Now, if a patient arrives here, we're still going to treat them with the same intensity, even though maybe core measures say we're not going to have to present that chart to them. So just know this, that a lot of the exclusion criteria, the critical care nurses may not even know all the exclusion criteria because they're going to still try to treat them to the best of their ability, as which all of us would do, I know that. Time zero is really important, that we know when that clock starts ticking, because we have timelines associated with these core measures. So CMS says the time at which the last sign of severe sepsis or septic shock is noted, or the last qualifying lab value was reported. There is a statement that talks about patients who enter the ED with severe sepsis or septic shock. If criteria is met when they arrive, time zero will equal triage time. But the reality is most of our patients don't have that lactic acid drawn yet and don't have other labs done yet. So most likely it will be later than triage time. But the whole purpose of this is to have quick and rapid turnaround times and being able to turn our patients around in a timely manner. Now let's cover the bundles. The 3-hour bundle for severe sepsis says that we need to have our initial lactate drawn within 3 hours, as well as blood cultures prior to antibiotics. And notice on the slide it has an NP by that item. NP stands for nursing protocol, which we have protocolized this to where if patients meet criteria, nurses can draw a lactic acid level house-wide, as well as blood cultures house-wide. The other parts of the 3-hour bundle are that broad spectrum antibiotics need to be given, and then the 30 ml per kg of crystalloid fluid. And those two have to be definitely ordered by the provider. Now the 6-hour bundle says that we need to repeat a lactate level within 6 hours if that lactate is greater than 2. So I know they don't meet criteria for septic shock until they're greater than 4. However, if it's greater than 2, that's still considered organ dysfunction, and we need to repeat that lactic acid level. That has also been nursing protocolized, so nurses can grab that and redo that lactic acid if it's elevated. Then for septic shock, vasopressors if hypotension persists, and then volume status and tissue perfusion reassessment if hypotension persists. So we will talk through what that looks like in just a moment as well. So just as a reference, as a refresher, initial lactate levels need to be drawn within 3 hours of presentation, broad spectrum antibiotics within 3 hours, and our hospital's goal is to give antibiotics within 1 hour. That is a measure that we present to the Joint Commission, and that's one of our personal goals at this hospital, instead of the 3 hours, to get those done within 1 hour. Also, blood cultures should be drawn prior to antibiotic administration if at all possible, and then we need to repeat that lactic acid level drawn within 6 hours if that initial lactate is greater than 2. As far as management for these septic shock patients, we need to resuscitate them with the 30 ml per kg crystalloid within 3 hours of presentation of septic shock. Fluids that we can give that are acceptable are lactated ringers as well as normal saline. And we also need to have an administration time. So it's not good enough to say give 30 ml per kg now. We need to say give 30 ml per kg over a prescribed amount of time. So making sure that that gets done within 3 hours. And our goal, I would just say, if we put it over an hour, that should be adequate. Vasopressors within 6 hours of presentation of septic shock only if persistent hypotension persists after fluid administration. And then we also are going to need to repeat volume status and tissue perfusion assessments within 6 hours of presentation of septic shock only if persistent hypotension persists after fluid administration. So let's talk about what persistent hypotension means. It means 1 hour after administration of crystalloid fluid, there are 2 consecutive single pressure readings of either a blood pressure systolic less than 90 or MAP less than 65, or a decrease in systolic blood pressure by greater than 40 points. Now, let's quickly review what the guidelines say about vasopressor use. We recommend norepinephrine as the first choice of vasopressors. You can see here in this meta-analysis that norepinephrine won over dopamine. So norepi will be our first-line drug for vasopressors, but we also can give dopamine as an alternative vasopressor agent to norepinephrine, but it's in highly selective patients, people at low risk of tachyarrhythmias or with a relative or absolute bradycardia. And then there is a suggestion in the guidelines for epinephrine that can be added to or potentially substituted for norepinephrine when an additional agent is needed to maintain blood pressure. Now, another guideline is vasopressin. 0.03 units per minute can be added to norepinephrine with the intent to raise MAP to target or decrease norepinephrine dosage. So usually in the critical care areas, we start with norepinephrine, we then add vasopressin, and then we add additional agents as needed. You can see there phenylephrine is not recommended in the treatment of septic shock except for in very specific time periods. For instance, when norepinephrine is associated with serious arrhythmias or cardiac output is known to be high and blood pressure persistently low, or as salvage therapy when combined inotrope/vasopressor drugs and low-dose vasopressin have failed to achieve that target mean arterial pressure. Now let's talk quickly about the focused repeat volume status and tissue assessment. We can actually do that one of 2 ways. Per core measures, you can do a focused exam by the provider. Mid-levels are all included there, nurse practitioners, physician assistants, and physicians, and include all of the following. You can see the list there. There's quite a few things that have to all be there. Vital signs, including blood pressure, pulse, respirations, and temperature. Cardiopulmonary exam, heart and lung evaluation, capillary refill exam, as well as peripheral pulse evaluation, and skin examination, including color of skin. Now, what we've done is we have actually made a progress note for you. And in a second, I'll show you a picture of that on the screen. But it is bright orange in color so that you can easily identify that, okay? What we've done on this bright orange sheet, it's a physician progress note, and we've allowed a spot there for you to do the assessment to determine their screening for their surge criteria, what their known or suspected infection is, and the organ dysfunction criteria that's present for the patient. And then it goes into the bundles, the 3-hour and the 6-hour bundle. And then on the back, it has a place for this focused exam. So as we talk about that, you may hear about this sheet that we're going to be referring to. Here's an example of this form that I was just showing you that's bright orange. It's not bright orange on your screen, but it will be in the real world. And notice on that second side over to the right, you can see where you have also a place for that progress note for that specific vital signs and your different exams that I just discussed. Then also below there, you'll have the other item that you could do as well. So you can also do any two of the following. You can do central venous pressure measurements, and you can see those in the nursing notes and then bring those over into your progress note, and you can just document it right on this orange sheet if that's helpful for you. We can also do central venous oxygen measurements, and you can see those in the nursing notes as well, as long as we have a central line with the endpoint in the superior vena cava. So it must be either a subclavian line or a jugular line with the endpoint in the superior vena cava, and we'll be able to get CVP readings for you as well as central venous saturation readings. You can also do bedside cardiovascular ultrasound, and basically you need to document the date and time that that was done. And it doesn't always have to be exactly at the bedside. You're going to want to do you can do an echo or a TEE or a Doppler echocardiogram, whatever you would like to do. And then we have a place where you can document that on that orange form as well. You can also do passive leg raises or a fluid challenge and then document the response to that. And I'm going to go over that with you a little bit over the next few slides. Let's talk about central venous saturation just for a second. Central venous saturation equates to tissue perfusion. So we're able to draw a venous saturation or a venous blood gas off that central line that we talked about with the endpoint in the superior vena cava. And notice we can determine or help determine how well perfused that patient is. The goal number is 70%. And if it's lower than that, then we think they're hypoperfused at the tissue level. If it's extremely high, then we know that the patient has the supply but is not utilizing that at the tissue level. You can see on the right-hand side, the oxygen consumption side, you've got metabolic demands. So if we can try to take care of the patient's fever, pain, anxiety, shivering, and muscle activity, hopefully that will help increase central venous saturation. But then we also need to look at the oxygen delivery side. So looking at hemoglobin, oxygenation, and then looking at our patient's cardiac output, which we know cardiac output is heart rate times stroke volume being the combination of preload, afterload, and contractility. So looking at those items as well. And we do hemodynamics at the bedside in the critical care units, so feel free to, we utilize FlowTrack at our hospital, so feel free to ask us any questions about that. Now this is just a pictorial, just if you're a visual learner, of central venous saturation. So if you think of the lungs as your train station, and think of this whole thing as a train station, and your cardiac output is your engine, and you can see your cars are your hemoglobin, and your oxygen is what we're filling up at the station, the lungs, and as it goes around the body, there's oxygen that's delivered, there's tissue demands, oxygen is extracted, and whatever's left over is central venous saturation. It correlates with SVO2, it's just not all the way in the pulmonary artery to measure that. Another thing we can do is we can optimize cardiac performance. So you can literally look at your patient's stroke volume, and we're able to do this with an arterial line and able to monitor and FlowTrack. We're able to monitor stroke volume, and as we give fluid, if they have a 10% increase in their stroke volume, the thought is that they're on the upward portion of their Frank-Starling curve and they could benefit from volume. So we have a great ability to be able to document stroke volume and give volume and then see how well they've responded to that. Another thing you can do is what's called a passive leg raise. Passive leg raises are kind of, I call it the poor man's fluid bolus, right? Because we don't have to, there's no cost in this, right? So if you lay your patient flat, lift their lower extremities, It takes a couple minutes. And if you look at stroke volume before you lift their legs, or you look at their, you can look at their stroke volume if they have a 10% increase with their stroke volume after you've lifted their legs. That volume that goes back to the heart, if you can see that it has a 10% increase, the thought is that they would benefit from volume. We have protocolized some of these items in the critical care units to make this easier for the providers. So in the ICU, if a patient arrives and has a central line, we can automatically connect them to CVP monitoring and monitor that, as well as if the patient has an existing arterial line and they've got hemodynamic compromise, we can go ahead and connect FlowTrack to that so we can get some of those numbers for you. We've also protocolized central venous saturation. So if they come to us with a central line, once again, if that endpoint is in the superior vena cava, we can draw a venous saturation and we'll have that SCVO2 reading for you. So we've already discussed about the volume status and tissue assessment. The time for this repeat volume status and tissue perfusion assessment starts at the crystalloid fluid administration date and time and stops 6 hours after presentation of septic shock date and time. Focus assessments must be documented by the provider, and we can use consult notes, ED records, H&P for that information. It can be from multiple sources, but we cannot use all of nursing documentation for focused exam. Now you can see here, this is a busy slide, but basically just kind of gives you a quick glance of the plethora of data that we have been gathering on our sepsis patients. And we've been mainly tracking our septic shock patients, so I'm really anxious to see what the data is going to look like for October as we look at not only our septic shock patients, but our severe sepsis patients. And you can see per the data, we do a pretty good job with those lactic acid levels within 3 hours and blood cultures, and pretty good with those broad spectrum antibiotics. Probably our biggest opportunity will be that 30 ml per kg of crystalloid within 3 hours if the patient meets criteria to have that. You can see here, this is on WSP portal. Right in the middle there, you see the arrow pointing to the sepsis icon. This gives you a link that will show you the latest guidelines from the International Guidelines for Management of Severe Sepsis and Septic Shock. And so if you click on that, you'll be able to get the Cliffs Notes version as well as a full, complete, documented version. And there's also documents over to the right. You can see documents for adult severe sepsis. So if you have questions or want to look at any of the forms, they are listed there as well. The references for today's information came strictly from the CMS Specification Manual for National Hospital Inpatient Quality Measures, as well as the Dellinger Surviving Sepsis Campaign International Guidelines for Management of Severe Sepsis and Septic Shock. If you have any questions, like I said, please let me know as you see me around in the hospital. I look forward to working with you on this great initiative.